Good afternoon, everyone, and good morning to some and good evening to some in the other parts of the world. Um, I'm Matthew Verghese, and I'm introducing Professor Ian Roberts. He's a professor of epidemiology at the London School of Hygiene and Tropical Medicine. He trained as a pediatrician in the United Kingdom and then in epidemiology at the University of Auckland, New Zealand, and McGill University, Canada. He is a clinical academic who works collaboratively with health professionals worldwide to conduct large, multi-center clinical trials aimed at improving patient outcomes in life-threatening emergencies. This is what he sent to me when I asked him, how do you want me to introduce you? What he didn't say in that, because his main research interests are prevention and treatment of injuries and links between energy use and sustainability and health. He is an author of a book, The Energy Glut, that is there, and he is passionate about his ideas on energy use and the car use and how it has contributed to obesity and problems of cars on the roads. He works with others to build global research partnership to answer questions together that could not be answered by working alone. He has played lead roles in several large trials. I don't know how he gets the energy in multi-country, multi-centric trials, Crash 1, Crash 2, Crash 3, you name it, and they're all there, out there published in the literature, and the woman trial and the HALT trial. All of them are there, and he's been passionate about them, trying to generate evidence-based medicine for practice in what we are doing in healthcare. Thank you, Ian, for all that you do, and thank you for agreeing to be part of this session.
Thank you, Matthew. That's very kind of you. So, all right. So, Matthew Matthew explained. I love. I think injury prevention is very important, and the links between sustainability and climate change are very obvious. But this presentation is about treatment. And I feel there's no need to be ideological, like prevention is better than cure. I think we should just do what we can to reduce death on the roads, and better treatment, I'm going to argue, is actually one way we can potentially very readily reduce death rates on the roads. And for a long time, we didn't have an effective treatment. And so, it was very difficult to advocate in this area, but now I believe we have, and I'm going to tell you about that treatment. So in about 1950, this woman, Utako Okamoto, started working on a treatment for postpartum hemorrhage. She was very, she trained as a doctor and then went into research. And in those days, Japan was a poor country, and women used to deliver their babies and bleed and die, just like they do in many parts of the world today, but primarily sub-Saharan Africa and South Asia. And she hoped to find a treatment for postpartum hemorrhage. And she was just a very incredible person. This is in post-World War II Japan. And she married another scientist. He's in the background. He's Shosuke Okamoto, and that's their daughter in the foreground. There was no childcare in those days, so they took their so they all worked and lived together in this lab. And they knew that when someone starts bleeding, the body tries to stop the bleeding by forming a blood clot, and these yellow strands are strands of fibrin blood clot. But they also knew that there was an enzyme in the blood called plasmin that chops up this fibrin blood clot. And, it's almost like, it's like a sort of a nylon um, mesh. You can imagine it like that, and someone's taking a scissors to it and cutting it. So plasmin is this enzyme that cuts up this fibrin mesh. And they thought, well, I wonder if we can find a drug that inhibits this enzyme. And they started looking, and they screened lots and lots of compounds, and they found out that the amino acid lysine was very strongly inhibitory of this enzyme plasmin. And they were clever biochemists, and they developed a molecule, you can see it here, called tranexamic acid, which is almost the same shape as lysine, but it's kind of, it sticks in the site. Um, it sticks to plasmin more strongly and inhibits this drug. So they'd invented this drug, tranexamic acid, which inhibits the enzyme plasmin, which gets in the way of blood clotting, and it was really effective. This is this way of expressing results. I should just talk about. It's very common in medicine, but it's not um, similar. It's not common in other areas of study. So basically, when we have, the best way to find out if a treatment's effective is by doing a randomized controlled trial, and you randomly allocate people into two groups. And because of this random allocation, the two groups have an identical prognosis at baseline, except one got the treatment and one didn't get the treatment. And so any difference in the outcome between the two groups is due to the treatment. Now, we generally express the results of randomized trials as a ratio of risks. And it's the risk of the outcome in those who got the treatment divided by the risk of the outcome in those who did not get the treatment or got the placebo. So if the ratio is 1, it means the risk in those who got the treatment is the same as the risk of those who didn't get the treatment, and so the treatment's ineffective. If the ratio is less than 1, it means it suggests the treatment's better. And if the ratio is greater than 1, it suggests the treatment's worse. Now, we normally present these risk ratios as a little diamond, and the kind of thick part of the diamond corresponds to the actual risk ratio. In this case, it's 0.62. And then we've got the tips of the diamond is the sort of confidence interval. So it's the range of values that's compatible with the play of chance. And you can see here that this shows very strong evidence that getting tranexamic acid, if you're going to have an operation, reduces your risk of needing a blood transfusion or dying. So we saw this evidence. We thought, my goodness, look at that. This drug that was invented in Japan in the 1960s, 50s and 60s, really reduces surgical bleeding. If you give it to a surgical patient, they bleed less. I wonder if it will work if we gave it to trauma patients. I mean, trauma is a bit like surgery. You know, if you get your stomach opened up by a machete, it's not that different if you're getting it opened up by a surgeon. So let's see if it works in surgery. I should say that just before I get there, some very big trials in cardiac surgery show that, really strong evidence that this stuff really works. Less reoperation, less transfusion if you get tranexamic acid. So we wondered, well, look, does it work in trauma patients? Trauma patients are a bit like surgical patients, and for a long time there was no effective treatment for traumatic hemorrhage. This paramedic in the back of an ambulance in the United States putting up his hands, what can we do? We don't know. So we did a very large global trial. So lots of trauma patients like this one. This man's been run over in Thailand. And we did a big randomized controlled trial called the Crash 2 trial. And I mean, conceptually, it's very simple. The hard bit is actually getting enough patients. But what you do is patients come into hospital with major trauma after a car crash or a shooting or a stabbing, and they get randomly allocated to get tranexamic acid all placebo, and they're in identical vials. Nobody knows who got what until the end of the trial when you crack the code. And all the other treatments, doctors are free to give whatever they want to do whatever they want, but any difference in outcome between the two groups is due to the treatment. And then we just got this fantastic result. So just like in surgery, tranexamic acid reduces bleeding in trauma, and it reduces the risk of bleeding to death by about a sixth, by about 15%. And the the diamond here showing that the tips of the diamond, the confidence interval of quite a lot of blue space between that and the line of no effect. So this is a really, the p-value there is very small. This is not a fluke. This is an effect of tranexamic acid. So tranexamic acid's reducing the risk of bleeding to death. But it's even better than that, because this was a very big trial, and we can look at the how other factors influence the size of the treatment benefit. And we'd planned to look at time to treatment, because time to treatment is very obvious. If you give the treatment late, it's not going to help, because tranexamic acid works by preventing bleeding, and so you have to give it as soon as people start bleeding and not too late. If you give it in the first hour, a 1/3 reduction in the risk of bleeding to death. If you give it in between 1 and 3 hours, a 1/5 reduction in the risk of bleeding to death. If you give it late, it doesn't work, and it might even, and according to this particular analysis, it could even be harmful. Subsequent analysis haven't confirmed the late harm, but they've strongly confirmed the early benefit. But anyway, if we give tranexamic acid to bleeding trauma patients within 3 hours of their injury, they're much less likely to bleed to death. And the first people to get very interested in this results was in fact the army, the British Army. And so the British Army started using tranexamic acid in Afghanistan and Iraq. The American Army were skeptical, because this was, after all, this is a British result. Also, they saw it, and might not apply to Americans. It's a very common way of thinking, but to me, scientifically doesn't really make a lot of sense with me. But anyway, they did a little study, and they did a study in I've forgotten what it's called. Camp Bastion. Camp Bastion in Afghanistan. Camp Bastion was a big sort of fort hospital, and soldiers that came in who were treated by British medics got tranexamic acid. Those who came in who were treated by American medics did not. And then they looked at the two groups. Now, this wasn't a randomized trial, but what they found was that on average, the soldiers that the British doctors treated were sicker, but still they had lower death rates, significantly lower death rates. And on the basis of this data and the Crash 2 data, the American military started using tranexamic acid. At one stage, I was invited to talk to American military generals, American military medics, about tranexamic acid, and they're not sort of they're not epidemiologists, they're surgeons predominantly. And so how do you express a 1/3 a relative risk of 0.68, a 1/3 reduction in hemorrhage deaths? So I went to Arlington Cemetery, and I photographed this hillside that has 100 graves in the picture, and these are all graves of soldiers who were killed in Afghanistan and Iraq. And then I photoshopped a 1/3 reduction, and it looks like that. And nobody would say that that's not significant. Turning that into that's an important benefit. And so and they got that. So obviously everybody's going to ask about side effects. This is a drug that helps people to form blood clots by stopping blood clots breaking down. And you're worried you're going to, you're going to reduce bleeding, but you're going to cause unwanted clotting. Well, the really nice thing about this is that it didn't. So this if we just look at the first line, any thrombotic event, there was 1.4% in the tranexamic acid group and 2.1% in the placebo group. In other words, there was a statistically significant reduction in clotting, in unwanted clotting, heart attacks, strokes, and things with tranexamic acid. So everybody worries about the side effects of tranexamic acid, but thrombotic side effects, it didn't have any. In fact, it prevented them. And so,
Can I
people,
interrupt
yeah,
here?
go
Can I?
ahead, Matthew.
Yeah. You know, way back in the time when you did the Crash 2 trial, my hospital was part of the program.
Yes.
We were fascinated by this. And at the next meeting, when there was a policy guideline to be made for, pre-hospital care, emergency care for road traffic victims, I proposed that tranexamic acid seems very promising with very little side effects. And other than one more person who knew about the crash trial, everybody else in the room, about 40 people, they all objected that here is a drug which promotes the clot to stay there and not be washed away in the trauma victim. Um, this can also encourage thrombosis, causing strokes in vulnerable people or thrombosis in the coronary arteries in vulnerable people, and deep vein thrombosis as a big risk, and pulmonary embolism as another risk. So they strongly vetoed my suggestion down, saying that no, 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 unless we have full safety profile, you cannot allow this drug to be recommended for emergency use.
Yeah, I think some of it, I think, actually is, strangely enough, it's sort of academic conflict of interest, because when the Crash 2 trial published, the results were actually quite certain. I thought, I've never seen anything look so good, but people saw it as an opportunity to get grant funding to do trials in their own country of tranexamic acid. So Australia said, Australian doctors said, well, look, we need to we need to confirm this in Australia, and American doctors, US doctors said we have to confirm this in the United States. And so then they had to make a sort of case for why do we have to confirm this in other places, because it was done in 40 countries, just not the US and Australia. And when you shoot or stab or car crash an Australian or an American, they bleed just the same anyway. And they did it by they tried to get trials funded by overstating the safety risks. That's one of the things, I think. The other thing, to be fair, is that they had a lot of people had invested in a drug called activated factor 7A without not on the basis of any trial results, but on the basis of quite aggressive marketing by the pharmaceutical company. And that did cause unwanted clotting. It did. And so they were very sensitive to this one.
Can I add a point here? Uh, you know, these very people that were refusing to accept tranexamic acid, many of them have been quoting those literature studies, small sample size with the increasing thrombosis effect, increasingly to say that no, this is not to be used.
Yeah.
Also, your own study, which is actually completely different from trauma victims, the GI bleed patients, the HALT it trial, which looked at the bleeding in upper GI with an increasing thrombosis. So they quote this, and then the policymakers then listen, okay, there are side effects, and therefore we cannot recommend this. That becomes an issue there.
Yeah, I think, drugs do have side effects, but you've got to be driven by the evidence, and this is the evidence from trauma. I'm going to show you more evidence in a bit, but if you give early tranexamic, there's just no evidence that it increases thrombotic risk. One thing, I mean, it's an anecdote, but it's quite persuasive in a way, is that um, the most common use of tranexamic acid in the world is as a beauty treatment. Um, well, so-called beauty treatment. Japanese women, Asian women like to lighten their skin, and one effect that tranexamic acid has is on a melanocytes. It slightly lightens the skin, and so it's sold over the counter, and women take about 75 milligrams every day to lighten their skin. So, and they're not dropping dead with thrombosis here and there and everywhere. But anyway, I'll move on. So the treatment works everywhere. This is the red diamond is the treatment effect, and these show it works in these treatment Asia, Latin America, Africa. They're not statistically different from the main effect. So the treatment works everywhere, and we estimate that if we only treated patients, this was an analysis that we did of if we could treat patients in hospital. We weren't treating them at the scene, but we did a sort of modeling exercise. We could save about 120,000 lives per year with very sort of conservative estimates of when people are treated. So, you can save an awful lot of lives with tranexamic acid. The places that you'll save the most lives are India and China because of the huge populations, but also uh, you know, also the United States. They love to shoot each other in the United States. They think it's a constitutional right. And in Brazil, there's a lot of both road trauma and violence. So we could save a lot of lives. It's a very relatively easy thing to do to save lives, and it's very cost effective. This is a cost effective analysis. If you had $1 million to spend, and you wanted to get by the most benefit you would spend it on insecticide treated bed nets, because that's the most cost effective intervention there is, if you've got malaria, of course. But closely behind that is tranexamic acid for trauma. You could save 20,000 life years for 1 million US dollars in bed nets, 17,000 life years if you invested that 1 million in tranexamic acid, 800 life years if you invested it for antiretroviral treatment for HIV. And the whole world has said, and quite rightly too, that everybody who has HIV should get antiviral treatment. But why haven't we done that for trauma victims? Why are this antiretroviral treatment is for the whole of the rest of your life. This is a single injection on one day of your life. So it was added to the WHO list of essential medicines in 2010, but that doesn't mean anything. It doesn't mean this is going to happen. Anyway, after the CRASH 2 trial, isolated head injury was one of the potential contraindications, and we thought, well, is it a contraindication? So people have put it there because they're very cautious, but we wondered if it was a valid contraindication. So we did another big trial. We did the CRASH 3 trial, where we randomly allocated 13,000 patients to get tranexamic or not, and the results are exactly the same as the CRASH trial, as the CRASH 2 trial. So in a way, the CRASH 2 and the CRASH 3 trials are just two parts of one big trial. And combined, they clearly show that tranexamic acid reduces death, predominantly on the day of the injury, but they reduce, they reduce the chance of dying from your trauma. And then here we got, they've done a few other little trials in the United States. This Rowell 2020 and STAMP trial, these are small trials that they did in the United States to prove that the results were the same, even in Americans. Because they were small, the confidence intervals are very wide, but the results are entirely consistent with the crash trials. And actually, when you add them into the crash trials, the treatment gets, the results even get more persuasive. And here you can see, we can't be sure. This is the effect of tranexamic acid on vascular occlusive events. We can't be sure, beyond all reasonable doubt that it reduces them, but there's absolutely no evidence that it increases them. Now, the critical thing with tranexamic acid is that early treatment is essential. And we did some fancy statistical modeling, and we found that the survival benefit falls by about 10% for every 15 minutes delay. So you really got to do it. It needs to be given at the scene. And so this is ambulances and paramedics, or as soon as you hit the door of the emergency department. We looked. Sorry, Matthew.
Can I interrupt you here?
Yeah.
Because the drug, to be effective, has to be given within 3 hours.
Yeah, after 3 hours, it's not particularly effective. It's not effective at all. Yeah.
So the challenge is, beyond ambulance drivers and the paramedics, how do we reach out for implementing on a larger scale?
Yeah.
Because the evidence is strongly in favor of the drug, and in fact, it's one of the few drugs which have been proven. Enough studies from world over that it helps. But the challenge here is, it is safe to be implemented widely. How do we bridge that?
Yeah, in the UK, well, one of the challenges is that in the crash trials, the crash 2 and the crash 3 trials, it had to be given by intravenous injection. And that's sort of a little bit complicated. It requires trained paramedics and not, and then we did another study in some big trauma centers in the UK, and we found that it's very well absorbed after intramuscular injection. So you don't actually have to have highly trained paramedics. You can have a pre-filled syringe of tranexamic acid, and you can squirt it into the patient's muscle, and it's very rapidly absorbed. It's very well tolerated, and it gets to therapeutic blood levels really quickly. So this is one way. So,
that certainly answers my question on implementation and scaling up. Because intravenous access in the pre-hospital setting has been one of the biggest challenges.
Yeah.
There are studies which talk about the number of minutes it takes, even up to half an hour it takes to get an IV access.
Yeah, you're right.
Which you can have IV access. So this mode of administering the drug can be a game changer in terms of implementation.
I think you're right, Matthew. I think this is like, lots of countries. So, for example, in Pakistan, I know that they have, they've developed a very, very, they've got a new sort of ambulance service, but the people who work in the ambulances, they're not trained paramedics. They might not be able to give an intravenous injection, but they could easily give an intramuscular injection. And I think if we can make this part of paramedic identity, I think that would be really good. The British Army now are working on a tranexamic acid auto-injector, so that, if a soldier stands on a mine and finds themselves bleeding, they can inject themselves or their colleague or their buddy. Whether we can have a low enough cost auto-injector I don't know, but you could imagine even police officers, who are often the first to arrive at the scene, could inject it. But I think that's probably a little bit down the track. So I, this is my leg in the upper right hand, and my daughter's injecting me with tranexamic acid. I wanted to know whether it hurt. And so she's injecting 5 mils into my thigh, and it doesn't hurt, surprisingly. Um, uh, I thought 5 mils is a rather big injection, and I thought this is going to be very painful, but it doesn't hurt even in a healthy volunteer like myself. So in a patient with trauma, I don't think it's going to hurt at all. This is some media coverage of our paper about
Ian,
intramuscular use.
Ian,
Mm-hmm.
you're doing something which many pioneering healthcare professionals have done, starting with the smallpox vaccination
It's a
and
bit. It's a lot
also
safer than that.
the H. pylori, the H. pylori,
Ah,
uh,
yeah,
the bacteria was swallowed by they won a Nobel Prize for that. They
yeah.
swallowed. So you're trying to follow them, or because
Oh,
normally
yeah.
we don't recommend this mode of self-administrating trials. Um,
No, I know. I don't think there's any Nobel Prize in it, but we had to make a training video, and I couldn't get anybody else to do it, so I did it. So in a way, tranexamic acid is almost like intramuscular tranexamic acid. We can think of it as sort of a vaccination against bad bleeding. And so anybody who's in a car crash, a car crash is a high velocity event, and you're at you're at significant risk of bleeding. So you should have an intramuscular injection of tranexamic acid. It's just like a vaccination for life-threatening, and it will reduce your risk of dying by over 10%. I mean, it's not going to guarantee you're going to survive, but it makes a significant difference. And all these, at population level, if we can shave 10% off the, I don't know how many 2 million people who hemorrhage to death by the roadside, that would be really nice. And the reason, people say, well, why are you only talking about tranexamic acid? Why you keep on going about this tranexamic acid? It's boring hearing about this drug all the time. Well, as your review showed very nicely, Matthew, it's the only thing that we've got really good evidence that's effective. So you said, other than tranexamic acid and painkillers, there's very little role for any drugs in the pre-hospital setting for trauma victims. I think, that your statement is spot on evidence-based currently. I hope there'll be other drugs in future, but I don't know of them right now.
just completed an evidence gap map on the pre-hospital care, and our evidence for anything else has been very low for interventions in the pre-hospital setting.
Yeah, no, that's true. So this is the last slide. I mean, this is the challenge. It's like we've done the science, but now we've got to do the implementation. I mean, like we did a big, it works in surgeries, very strong evidence, big trial in trauma. People say, what about head injury? Big trial in head injury, similar results. Well, but it's too complicated to deliver at the scene. Well, we've shown it can be delivered by intramuscular injection. So lots of the science is done, but that's never enough. The science on its own is never enough. And actually it just takes a lot of advocacy. And in fact, Maria, in the last talk, I really enjoyed her soundbite. That advocacy can speak loud, but money can speak louder. And that's one of the problems with tranexamic acid, is that it's an inexpensive generic drug. So big pharmaceutical companies make their money by having very expensive drugs, sort of low volume, high cost. I hope that because this is a generic drug, and lots of companies are making it all around the world, maybe there could be a sort of high volume, low cost model for making this worth someone's while. But we've got to have a push from below, a pull from below from victims organizations. That's why next Sunday on the 15th is World Day of Remembrance for Victims of Road Traffic Crashes. And we're working with victims organizations, the European Federation of Road Traffic Victims, and they're with us. We're calling for, better implementation of tranexamic acid in bleeding trauma patients. And
Um, just to add on to that day of remembrance, there's another day which is March 31st, which is taken as the Stop the Hemorrhage campaign.
oh yes,
So that's a March 31st. It was arbitrarily chosen,
yeah,
but it is a Stop the Hemorrhage Day.
yeah,
So wherever the patient is bleeding, you need to stop the hemorrhage. So March 31st is also another day.
mm,
But these days and weeks only help us, as Dinesh always mentions, these days and weeks only help you to bring it to the notice of certain people. Beyond that, it doesn't really work.
yeah,
So, just to one more advocacy point, as Maria mentioned, that money talks better, and being a generic drug, many people may not realize this. If you have a new drug, the company that manufactures it has a patent on it.
mm-hmm,
And the patent may last for 10 years or 20 years. After that, anybody else can make it. If everybody
yeah,
is making it, the drug becomes cheap. And as long as the patent is on, the drug is expensive.
mm,
So the average victim of injury may not understand this, or an average patient may not understand this. The patent adds to the cost and money talks, and everybody is keen to market it as long as the patent is on. A generic drug, the money that they make, the profit that the druggist also makes is also low.
yeah,
And therefore the push becomes much less. And this amplifying what Maria said in the last session.
yeah,
It has to be a push from below, maybe victims of the world unite, injury victims of the world unite, and then push from below, like a lot of things happened in medicine.
yeah,
The example we were discussing the other day,
mm,
club foot, for example, club for treatment. The treatment, the birth defect, very simple treatment was, you know, tried and tested by Ignacio Ponsati in 1946, did not become popular. 50s did not become popular.
mm,
60s did not become popular. 70s did not become popular. 70s surgery became popular. 80s did not become popular. It's only when the internet came into force, the parent groups pushed for it and made it popular, asking the doctors, you do that technique. So maybe we need to do something. I do not know how to push it because it's a generic drug.
yeah. Well, the victims organizations in the UK, there's a victims organization called Road Peace. It's the UK national charity for the victims of road traffic crashes. And we worked with them, and they sent freedom of information requests to all NHS hospitals every year, asking what proportion of injured patients got tranexamic acid. And that's quite, I think that caused the British government to take it very seriously. They just think, well, there's all of these people out there that's demanding this drug. And then these freedom of information requests come into a hospital, and they land on the chief executive's desk, and she or he says, well, are we using this in this hospital? What's this? And they pass it down to the director of the emergency department, and they have to think, well, I don't know, are we using this here? And so it does, these freedom of information requests do cause change. And now the victims organizations are demanding it at the scene, and the focus is on paramedics, and things are changing. But it's 10 years since we got this crash 2 trial result, and so it amazes me how slow things are to change.
It's in a way good. Some things are slow to change, but it's bad that some things are slow to change.
Mm.
I have a question here uh, from one. Would you recommend the same dosage or concentration of tranexamic acid for intramuscular and intravenous use?
Yeah, I think so. It's 1 gram, and 1 gram is because the solution is 100 milligrams per mil, so that's 10 mils, and 10 mils is quite a big injection. So two 5 mil injections of tranexamic acid, into the thighs or buttock or deltoid, and we've tried this, and patients. We've tried this in trauma patients. They don't object. They don't even notice it actually. Um, so, the more drug you get into the patient, the faster you get therapeutic levels. So yes, the answer is yes. Um, Give a gram of tranexamic acid by intramuscular injection. But I mean, if there's already an intravenous line, give it intravenously. But everybody says, oh, I can get an intravenous line in 2 minutes. But as Matthew told me a couple of days ago, the evidence doesn't support that. Um, I can't remember the figures, Matthew, but it takes much longer to get an intravenous line in than people claim.
27 minutes is the time taken by
Mm,
emergency technicians to get an IV access. Remember, getting an IV access, your veins are prominent if your blood pressure is good. In a bleeding patient, the blood pressure goes down. And when the blood pressure goes down, the veins are collapsed. So getting an IV access in the pre-hospital patient is going into shock or low BP is very difficult. And also in a field setting, when you're
mm,
surrounded by a crowd or you're in a moving vehicle, getting access to get that tip of the needle exactly into the vein is a psychomotor skill which has to be really advanced.
yeah.
So it may look simple in a hospital setting, but in a field setting, it may be difficult. And therefore, there are different alternative methods that are thought of for making it easy. And this IM dosage being effective, I think, is a game changer.
Mm,
And to go, I think we have time to go further on um, in the low income countries. In high income countries, we've looked at the data, about 97% of people are transported in ambulances. Whereas in low income countries, over 90%, 95, 96, 97% of people are outside of ambulances, the injured victims.
yeah.
Uh, how do we reach to them? So it has to be scaled up at the primary healthcare level, at the district hospital level, wherever the patient is taken first. Before anything, if he's bleeding, then this could be an answer. What do you think?
I think that's a very good idea. I mean, that's what we've noticed, that patients, um, ambulances are relatively rare worldwide. And the typical scenario is there's a crash, and then they flag down the nearest passing vehicle, and patients bundled into the back seat and taken to the nearest primary care center. And it's often, very basic hospital with or health center with a red cross on it, and they don't often do. Usually, they don't do much that's of great value. I mean, they sometimes take X-rays, they sometimes suture wounds, um, they sometimes give tetanus toxoid, and those aren't really what kill people. And X-rays don't not that much help. But if those sorts of places could give an intramuscular injection or intravenous injection, but whatever's quickest, intramuscular injection of tranexamic acid before, you know, putting a patient in a either private ambulance, which is what they often use then, or a taxi to go to the tertiary hospital, or actually sometimes it's to another slightly bigger hospital, which also can't provide definitive care. But um, if those primary healthcare centers could give an intramuscular injection of tranexamic acid, I think that would be very that would be giving them something useful to do that actually does make a difference.
Yeah, yeah. I don't have any questions here. I think if the participants have any questions, I could encourage them to ask questions. Um, but meanwhile, to continue with the discussion on how do you scale up the usage among the healthcare professionals? Not a lot of the gynecologists know about this just because of the historical usage in postpartum hemorrhage and in gynecological bleeding. But and a lot of surgeons use it routinely before major surgeries to
Mm,
reduce the amount of transfusions required post-operatively or per-operatively. I use it routinely
mm,
in my patients. But when I told my casualty medical officer on the usage, uh, on a wider scale, they were not aware of this,
mm,
that it could be used for a trauma patient. So I think there has to be a build-up into the curriculum of the nursing professionals and the doctors in the curriculum that this is something which is an emergency use drug for trauma victims.
mm. No, I agree with you. Lots of different things. So, for example, I know that you and Dinesh worked very hard to at government level to get this on the radar. And a couple of years ago, you sent me a policy document um, from an Indian government policy document that um, where tranexamic acid was cited as something that should be provided at ministry level. Um, that sort of activity is very important. It's
This
sometimes not enough. You've got to go from, as you say, you've got to have a cohort of emergency physicians that are trained, that know that this is part of you know part of history, really, and that they should be using this treatment routinely.
yeah, because unless it is widely used, um, you know, you will lose more patients
Yeah.
because the evidence gap map on interventions in the pre-hospital care show that very little is effective in all the things that we do and
Mm.
push for in ambulances all the time.
Yeah.
And here is a hard evidence that we have. And
Yeah. I mean, I know that most of the people listening to this call, listening to these lecture series, will be primarily interested in the prevention of road traffic crashes, and and that's But if in your talks you also mention post-crash care and the need for evidence-based treatments, and so um, early tranexamic acid treatment for all trauma victims, all victims of road traffic crashes, um, I think you'll be helping the cause, and then you'll be showing you're not ideological. You want to save lives, however, whichever way you can. In fact, in the UK, um, a large part of the reduction in trauma death over the last 20 years has been actually due to treatment. Um, that there's the case fatality rate, the proportion of injured patients who die, has fallen quite dramatically. So treatment, we mustn't forget treatment has a role to play. I'm for prevention, treatment, and rehabilitation, and I don't say one is more important than the other. It's just what works. That's the only criteria that, that I want to apply. Does it work? If it works, I like it.
certainly, certainly, I think that's an important point that you made there. That treatment is equally important because in low-income countries, because what they see in the high-income countries, all patients treated in ambulances, they are carried in fancy ambulances, highly, a lot of expensive equipment inside, but they're taken to a hospital where the treatment is below par.
Mm,
So that doesn't uh, help the patient as such. So you only shift the deaths from the roadside to the bedside in the hospital. And
yeah.
that's not what you want. We want the patient going back home. And that needs a continuum of care from the roadside to back home to wherever he lives. That's an important message that you give. Treatment is equally important.
Yeah.
Hospital setting.
And with tranexamic acid in hemorrhagic trauma, it's the nice thing is if you don't bleed to death, you actually recover fully. It's almost like, it's not, you don't have some terrible disability as a result of your blood loss. If you can actually stop people exsanguinating, you save a life without causing, there's no increase in disability. You've somebody who's, imagine, young person, they would have been dead, now they're alive, just as they, fully functional. So it's really good.
Yeah, but your Crash 3 trial, the findings are very significant because of head injuries.
Mm,
Um, Maria talked about the motorcycles, and the motorcycles are a cheap mode of transportation uh,
mm,
from end to end. Um, including the last mile connectivity is best with motorcycles, and no public transport can match the cost effectiveness of motorcycles.
mm,
But they bring on head injuries.
mm,
So the message that the traumatic brain injured patient is equally benefited by tranexamic acid injection given intramuscular uh, can actually save many more lives.
mm. Yeah.
I still don't have any questions coming up here. I know we have about 7 minutes left for this session.
Hmm.
Uh, no,
Well, we could, if there's no questions, we could finish early, or uh,
any other panelist wants to ask any question?
Matthew and Ian, it's Tony Bliss here. It's sort of interesting. I've been hearing about this. I get it pronounced it because of the
tranexamic acid.
tranexamic acid. Mark Stevenson been telling me about this for years. This is the only thing that we can talk about in post-crash that's got a proven benefit. And it's very good to hear, your presentation. And from my viewpoint, I sort of see it as, in a way, like you, Ian, and I assume Matthew, as in a sense a fairly easy sell. If one, I mean, one would have to have an idea of the average cost of the treatment, but like to have something that sort of works, and to have something that, with the emphasis on that we've put on first responders, particularly in lower middle income environments, to just have that one extra thing in the toolkit, a bit like the British soldier would have, to say, well, this is a fairly straightforward thing, and you just do it. So like, is it something to do with the way it gets sold? Well, this is like a helmet, or just, I mean, I don't see it in the global plan, for example, being promoted. It may be there, I may be wrong, saying this is something that's just a must. And that one look for the Gates or the people like that who are willing to say, well, we'll throw a bit of money at this to sort of get it in there. Like antiretroviral drugs for HIV/AIDS are very expensive, but they've been funded.
Yeah. Well, I think it's very interesting. It's something unique about trauma. So basically, after we got the great result from the Crash 2 trial, we did the trial that Japanese woman inventor of tranexamic acid wanted. We tried it in postpartum hemorrhage, and it reduced the risk of bleeding to death, just as it did in trauma. So it was, sorry, my phone's ringing. So it's highly cost. So anyway, it works in trauma. It works in postpartum hemorrhage. The WHO really took on the postpartum hemorrhage part of the story, so that, they believe that women everywhere should be, should receive this drug. And so there's a lot of policy effort, but it's just not the same in trauma. Now, the benefit you get from treating women with postpartum hemorrhage is, postpartum hemorrhage death is much rarer than trauma death. So I don't know. I just don't know. For some reason, trauma is the poor relation of policy. You know, people like, it's just the difference between the response to our postpartum hemorrhage trial and the trauma trial. Exactly the same results, almost numerically the same, and huge policy effort in postpartum hemorrhage and next to nothing in trauma. It's very striking, Tony.
I have a
And yeah,
question.
just a quick add to it, that if you note that the safe system approach that's sort of since the 2008 OECD report, which I was part of, it became a very popular framework, particularly in Australasia. The post-crash part was just sort of left out of that framework. And I mean, you'd always remind people, hey, you know, there's some big benefits here, but if your actual strategic framework hasn't even got it, that strikes me as a problem. So I think one way we can address it is just by how we show what the total system is, and where, you know, like when you have a proven intervention with the way you're describing it, no obvious bad side effects, a fairly high effectiveness rate, easy to do. I sort of find it interesting that it's not getting pushed as hard as it is. I'd heard about it because we were teaching a road safety management course at Monash University and going through the list of things, and that was something we were throwing in, saying, well, that's what we know in this area.
Yeah.
This is a good deal. But it's not really coming much through the road safety community is not talking much about this stuff. And so that's a sort of, and I think partially because that pillar has been left out.
Yeah. In the past, that pillar was left out because when you go, well, what can you be sure that's safe and effective? There wasn't a lot, like, Matthew's review showed. You could almost be more sure about things that didn't work than things that did work. But now we've got something that really does work. And so it's time for all road safety professionals like you and, in the fora that you're in, to add in this last pillar. And now you can really defend it. You know, you can say, right, tranexamic acid at the scene works. We should do it. Highly cost effective. You know, you asked about the cost of the treatment. It's about, £3.50 to treat one patient.
Right. Well, you know, to put it in context, when you see the drug testing going on in Victoria and Australia, on-road drug testing, the cost per test is very high.
Yeah.
The effectiveness of the operation on the general deterrence sort of sense is probably very low, because it's essentially turned into an apprehension model. Can I see someone who looks like they might be driving under the influence of meth, and then I'll test them and I can convict them? But I think from memory it was about $50 a pop.
I'll have to stop now because we have finished the time. Just a last comment. The Sustainable Development Goals talks about a 50% reduction in deaths. So tranexamic acid could be a game changer there. That's one.
Yeah,
And
it'll get us some way.
I think whether policemen can be given the charge of giving tranexamic acid, there could be licensing issues there, so that could be a problem. Last word from you, and we'll stop.
Well, just to thank you, Matthew, for sharing this session, and thank you to all the people listening. I know you came along for a talk on, your primary interest may be in the prevention of road traffic crash, but please don't forget post-crash care. And, if anybody asks you what works, tranexamic acid, and I'll make these slides available, and people can use them, use them freely. You just take a couple of slides, put them in your talk, and it helps spread the word. Thank you.
Thank you. So